Hello.
Yes, Phoebe, kindly go ahead and give us an opening prayer.
Let us pray. Father, kind, loving Father, we thank you for this evening. We thank you for whatever you have done today. Into your hands we commit our presenter, we commit our moderator, and we commit everybody on call, those who have joined and those who are coming to join, that may we open their ears to understand what we are going to stimulate so that we are able to help the people of Uganda and the world at large. We pray all this was Christ our Lord. Amen.
Amen. Thank you very much, Phoebe, for giving us that opening prayer. And we do appreciate you. Right now, we have 79 participants or attendees who are online. I'm going to request that we are able to mute our microphones so that we can be able to listen from our, not only the moderator, but our presenter for today. So once again, I welcome you all for this session where we are going to look at simulation skills training for obstetric emergencies, not only for midwives, but also for other health workers working in obstetrics and gynecology or maternity sections or midwifery areas. So I the moderator. My name is Lillian and Wabi. I am a nurse. I am also a midwife and I'm a women's health specialist. I do work with Aga Khan University School of Nursing and Midwifery, and I'm in charge of continuous professional development. I am humbled to be your moderator for today's presentation. So at this juncture, allow me to take you through what Busoga Health Forum is all about. So Busoga Health Forum is an association of like-minded people and professionals stimulating community, government, and partner actions for better health of the people. We are a national, not-for-profit, voluntary membership-based organization headquartered in the heart of Busoga, Jinja City. Basically, Busoga Health Forum works in collaboration with the Ministry of Health, local governments, and civil society organizations to coordinate health intervention through established technical working groups and technical administrative structures, including district health teams and formal and non-formal community structures. Additionally, Busoga Health Forum is therefore a think tank generating evidence to drive health policy action to improve the health and development of individuals in Busoga and beyond. So let us proceed. Our vision as Busoga Health Forum is a healthy, thriving Busoga. So let's see our mission as Busoga Health Forum: to rally Busoga professionals to use evidence to engage the community, government, and partner action for better health of children, youth, women, and men in Busoga. What are our core values as Busoga Health Forum? 1, value addition, collaboration and integration, impact focus, transparency and accountability, then effectiveness and efficiency. So as Busoga Health Forum, we have 5 core values. And at this juncture, allow me to repeat them. 1, value addition. Secondly, collaboration and integration. Thirdly, impact focus. Then the 4th one is transparency and accountability. And lastly, effectiveness and efficiency. So be part of the efforts to improve health in Busoga and also become a member of the Busoga Health Forum. I think when you view the screen, you can be able to see the subscriptions and also the people that you should be able to contact in order to be part of the Busoga Health Forum. Right now, I see we have 95 participants, and I know that even more are joining. Right now, we have 96, so we welcome you once again. So what are our core program areas as Busoga Health Forum? 1, reproductive, maternal, newborn, child, and adolescent health, which is RAMNA. Then secondly, our core program area is malaria, HIV, and tuberculosis. Our 3rd core program area is regional planning and data use. And then the fourth one is our program area as Busoga Health Forum is urban health. So in case you'd like to be part of the Busoga Health Forum, if you're able to have a look at the screen, those are the different areas or social platforms that you can be able to contact us as Busoga Health Forum on our website as www.busogahealthforum.org, and then on Twitter at Busoga Health, on Facebook Busoga Health Forum, and on YouTube Busoga Health Forum. And our email as Busoga Health Forum is info@busogahealthforum.org. Thank you very much. Yes, Ariel, are you online? I'm trying to see if our presenter is online because I see it is 13 minutes past time, and I would like to introduce her. So I would like to confirm if she's online. Ariel, could you be online? Yes, Ariel, I can be able to see you. May you kindly try to unmute and say hello?
Hi, can you hear me?
Oh, yes, yes,
Okay.
You're loud and clear.
Sorry, it wouldn't let me turn off the mute, so.
Oh, okay, but great that you're able to log in and also be able to unmute your microphone. So once again, we welcome you, Ariel, and allow me to introduce you so that our lovely attendees and participants can be able to know who our presenter for today. So Ariel Bernstein is a midwife with over 15 years of experience in maternity care. She ran her own private practice in Maine for the last 7 years, and also has been involved in teaching midwifery students as an instructor and preceptor. About Ariel, more about Ariel, she is currently a student at Harvard University pursuing her master's in public health, and is also expected to graduate this year, 2024, in May. So congratulations to you, Ariel, because you're just close to finishing. Well done.
Thank you.
You're welcome. More about Ariel Bernstein. She is in the Department of Global Health at Harvard University, and as I said more, she's also completing a double concentration in maternal and child health and also humanitarian studies. She is a mother of 2 girls and is currently practicing as a part-time midwife in one of the private centers, while she's at the same time, of course, completing her master's in public health. So well done, Ariel, and we welcome you to this platform of the Busoga Health Forum. We are looking forward to hearing from you and also to having a great presentation from you. So once again, before Ariel comes in, this is just to confirm that she will be giving us, or she's going to give us, a presentation on simulation skills training for obstetric emergencies. When I saw that Ariel will be taking us through that topic of simulation skills training for obstetric emergencies for midwives, in my mind I said, yes, I'm a midwife, but why only midwives? I say that obstetric emergencies, different health workers are involved in managing obstetric emergencies, not only midwives, but we also have other health professionals or cadres, be it doctors, be it clinical officers, be it, other health professionals involved in that. And that reminded me of something that once I wrote about, which I can just take you in 2 minutes, and then Ariel will be diving into her great presentation. One time I talked about midwifery care remains a key in managing complications of pregnancy and childbirth. And my thought was that while most of the pregnancies and birth are uneventful, all pregnancies are at a risk. And according to the World Health Organization, around 15% of all pregnant women will develop a potentially life-threatening complication that calls for skilled care that is provided by a skilled healthcare provider. It can be a midwife, it can be a nurse, it can be a doctor, it can be a clinical officer, and any other person that is involved in maternity care. And then I went ahead and said that the rise in medicalization of childbirth and the increase in women being treated for complications of childbirth creates a need to ensure the presence of midwifery services in the care of all women in order to ensure that the ethos of normal childbirth is maintained as much as possible. And it is therefore important to ensure that women experiencing complications in childbirth receive the best possible care from a multidisciplinary team, which should include a midwife. So the World Health Organization says that the childbirth is an event that lends itself to over-medicalization. And I think when I talk about over-medicalization, you all understand. And that's why we are seeing a worldwide increase in the number of cesarean sections where there is no clinical indication for some of the others. And, this leads to unintended, adverse consequences, not only for the infant, but also for the mother. But the International Confederation of Midwives, which is ICM, it believes that a woman who develops complications during childbirth and pregnancy, or even the postpartum period, requires care from a midwife in addition to care from a specialist or even specialist. So it is therefore appropriate that the midwife is always involved in the obstetric care and any other specialized care and in the treatment relevant to the mother or even the newborn. So in Uganda, this is actually greatly and highly evidenced in public health facilities, where we have midwives that are actually fully involved in the provision of midwifery care. But when you come to high-end facilities in our Uganda, and you can be able to testify, rarely will you find midwives involved in provision of midwifery care as it is supposed to be expected. So without wasting a lot of our time, it is 19 minutes past 8 p.m. here in Uganda, and I'm going to request our great presenter, Ariel, to dive into her presentation. So over to you, Ariel. Thank you very much.
Thank you very much, Lillian, and thank you to Busoga Health Forum for inviting me. It's really an honor to speak with all of you tonight and to share some more about the project that I was a part of in January. I totally agree with what you said, Lillian. Simulation skills training and preparing for obstetric emergencies, it's so important that everybody who's involved in birth, whether they're a midwife or a doctor or a nurse or another healthcare worker, that they have the opportunities for advanced training and continuing education. Our project specifically looked at midwives to recognize that midwives are, as you said, the primary people involved in maternity care, and that all pregnant women should have access to midwifery care. It's certainly, there's very big goals right now for the UN and for the WHO to really prioritize the education of midwives and make sure that there are enough midwives so that every pregnant person, no matter where they are, has access to a skilled midwife, to have a safe birth, and to have better outcomes. So our project, which we were very honored to work with Busoga Health Forum and Jinja Regional Hospital and many midwives from the Jinja region, to look at how we can use simulation training to improve emergency skills and continuing education. So I don't know, is it easier if I share my screen for the slides, or what's the easiest way to do it?
You share them from your side, Ariel.
I can share them?
I just want to be sure, Ariel, are you able to hear Ariel?
Yes, we are able to hear, and I request her to share the slides from her side. You're able to share.
Okay, great. Okay, so in January, along with Cathy, who's an obstetrician, we came to Jinja after 4 months of working with members of Busoga Health Forum to create a program to help with increasing capacity for simulation skills training. We looked at many different ideas for the project to help improve outcomes and resources, and we came to the conclusion that simulation training was a really excellent tool to implement in the region. Simulation training offers a range of benefits that contribute to improved patient care overall and healthcare outcomes, while encouraging learners to learn in an environment that is safe and supportive and risk-free. When we do simulation training, we can try to make it as realistic as possible with how emergencies present and how they're managed, but it also gives people the opportunity to practice new skills or skills that they don't feel as confident in a way that's really safe, because they're not attempting those skills on a patient during an actual emergency. So it gives the opportunity to really build clinical competence and confidence in the provider. And they're also able to get feedback during that time. So during an emergency, we all know we have to act very quickly. And sometimes we make mistakes or we forget a step because our adrenaline is rushing. We're trying really hard to respond to the emergency that's in front of us. And simulation training allows us to have that experience with also being able to step back and reflect and work as a team to really think about where we can improve so that we have that better, like, instant memory. So in the moment during an actual emergency, we will remember because we've practiced it. And with most things in life, practice makes perfect, right? The more we can practice something, the better we will do. And it's really hard when you only get to use those skills during an actual emergency to improve upon them, because you can't really stop and think about how you would do it differently in the moment, right? We just have to act. So we thought that simulation training is a really important tool. There's a lot of really large organizations, like I mentioned, like the WHO, Partners in Health, other major health organizations that are working internationally to promote simulation training, especially in maternity care, when we know that there can be so many unpredictable things that can happen. And part of being a really excellent provider and providing good care is to be prepared for unexpected things. So even emergencies that we might see very infrequently, the way that we can keep our skills sharp and be ready to respond is through practice. The other benefits are, for continuing professional development, because we know that sometimes what we learned when we first became a provider, whether you're a midwife or a nurse or a doctor, when you were first in school, we might now have better information or more studies or a better understanding of physiology or the event that we know we could do better now. I remember when I first became a midwife and how I was taught certain skills. Now we know we can do them differently and have better outcomes. So the importance of the opportunity to have continuing education is really important. It helps us continue to improve our skills, stay up to date, and make sure we're doing what's current best practices. So in early January, we came, we trained a group of 40 midwives total, 20 midwives in each group. Each group had 2 days of training, and we covered 6 common obstetric emergencies. We were actually trying to recount this yesterday, but I think it was at least 7 facilities that we had midwives that joined us from. So that was really great that we got to meet people from all over the region. As Lillian gave in the introduction, I'm a midwife. I've been in private practice here in the US for over 10 years. I've worked in mostly rural communities with lower resource settings. And I worked with Dr. Cathy Hahn, who's an obstetrician from Southern California. We're both students at Harvard University, and we're both pursuing our master's in public health. So our goal with the training, as I mentioned, was to improve provider skills, improve responses to emergencies. We know that the response time often makes a huge difference, but how quickly somebody acts and recognizes the emergency. So simulation training also helps people be able to learn the signs of identifying an emergency faster. Provider confidence, supporting a culture of teamwork, supporting a culture of continuing education, and creating an ongoing simulation skills training program. So our mission was to help midwives in Jinja improve their birth emergency skills. And our vision for the project was that through improved emergency skills training, there will be a reduction in maternal and neonatal deaths in Jinja. So these are some quotes from some of the midwives that we worked with when afterwards we asked how they felt during the simulation training. Especially about shoulder dystocia, we got a lot of great feedback on. So one person said it was an eye-opener, which has boosted my confidence. When we asked if they'll make any changes to their practice after the training, somebody said 100%, very much willing to save the baby's life. Good for you for coming, because we now have new good skills, which are enough to save life of mother who have postpartum hemorrhage. I feel great. I feel confident and great. This was a picture of one of the groups, and you can see the two dummy babies that we had for the training. They look pretty realistic. So these are the skills that we reviewed during the training. Postpartum hemorrhage, we talked about medication management, the WHO protocols, and something called the emotive protocol, which is was a large shift from it used to be that more the idea was to try medications in a specific order, and the emotive protocol, the shift with that is to give multiple medications simultaneously now, especially tranexamic acid. The idea is that tranexamic acid should be used as a first-line drug in all cases of postpartum hemorrhage when it's available. We also talked about preeclampsia and eclampsia, and we used the Laerdal Global Health Management booklet, which was also given to each midwife that attended the training afterwards. We also had some large decision tree posters that were sent to each facility that was represented at the training, so that that could be added to the delivery room space if they wanted to put that on the wall. We talked about breech birth maneuvers, especially hands and knees positions for breech and upright birthing, as a way to facilitate rotation and emergency breech delivery. We talked about cord prolapse. We really got into differentiating what the decision making should be about management of cord prolapse, either if the birth is imminent or not imminent, and what surgical capacity is available. We spent a lot of time on shoulder dystocia, about identifying it, team response when available, and different hand maneuvers and resolution maneuvers for shoulder dystocia. And originally we had only those 5 emergencies that we had planned to cover, but we, through a lot of discussion with the group while we were there, we also really talked a lot about neonatal resuscitation, because as you can imagine, if you attend births, it's not uncommon, especially if there's a cord prolapse, a shoulder dystocia, or a breech baby, that you will also need to resuscitate the newborn, and that those newborns that survive a birth emergency are more likely to need more help beginning to breathe. So we talked about neonatal resuscitation, especially the urgency of response, standard guidelines like the Helping Babies Breathe program, and use of PPV. Oops. We brought with us 2 simulators. One on the left is called Mama Natalie, and it's from Laerdal Global. And Mama Natalie has an infant called Neonatalie, and it can be used to simulate birth, normal birth, complicated birth. It has a compartment that it can simulate postpartum hemorrhage. We chose not to use it in that way because it would have required additional resources at the time, but it's capable of doing that, which is a really interesting training tool, especially since we learned how common PPH is and all of the risk factors that are present for it. So I think it's an excellent tool, especially for people who are newer to birth work, maybe new midwives, people who haven't seen a lot of hemorrhage yet and are still learning really to understand blood volume loss. The simulator can be filled with a fluid and can simulate bleeding. So it's really helpful for people when they're first learning to really recognize what is the quantity of blood and to give an estimation. And Neonatalie, the baby, has some very interesting features that it can be used to teach newborn resuscitation. The other simulator that we purchased is the Guarmard Advanced Simulator, which unlike the neonatal is all soft and somebody holds it in front of them, the other simulator is firm and can be, set up so that it's like a person on a delivery bed. And it also has internal pelvic markers that you can feel, which is really great especially for students. And when you're trying to practice the maneuver and thinking about where in the pelvis you're trying to reach, or where the pelvic markers are. So it's very helpful to be able to feel that. And this model also can simulate twin birth. And these are just some pictures of it being used during the, of practicing different birth maneuvers. So during the, when we first were preparing for the training and preparing to come to Jinja, we looked a lot about the different protocols, the Ugandan Ministry of Health protocols, and what training looks like for midwives and what resources are available. And we learned so much from the midwives that we worked with and got to speak with and really understand a lot more about the challenges that they face day to day in their jobs and the complexities of maternal health care in limited resource settings and lower resource settings. So we learned really about, the difficulty of limited personnel when often in the US, we're really trained to work in teams or, multiple people attending a birth at once. Excuse me. And it's a very different experience if you're the only person that's available and how you will respond to an emergency if you don't have help. So we talked a lot about that with the team, which really helped us as myself and Cathy really think through, different ways and different approaches then to teach different emergency response or to talk about how else somebody can handle an emergency if they're the only person. But we also talked about team response when it's possible, what that could look like, and the importance of trying to build a culture of team response whenever it's something that's possible to be done, especially when it comes to, complicated emergencies or emergencies when both the mother and the baby need assistance. We talked a lot about unpredictable supply chains, in terms of medication availability and supplies. It's obviously very difficult to talk about best practices with medication management if not every medication is always available, and how, difficult it is to really think through medication administration when from day to day that might vary about what is available and how that influences response to postpartum hemorrhage and hemorrhage management. And we learned a lot about cultural practices in the community as well that are sometimes a contributing factor to birth emergencies, especially uterine atony and postpartum hemorrhage. Like people using herbs and home remedies at home, either before or in early labor that might affect their birth outcomes. And the last thing that we had a lot of discussions about, both with the midwives and other medical staff, doctors, and hospital workers, was about infrastructure transportation. So when you're trying to maybe go from a health center 3 to a regional referral hospital, and the distance that needs to be traveled, road conditions, ambulance availability, how long it will take somebody to get there, and what, how stable they are to make that journey. And these are a lot of really complicated challenges for providers to face every day and to constantly be, making a plan in their mind about what's available today and how will I be able to use those tools to handle an emergency should one happen. This is just a little bit more on the benefits of simulation training, and how much it really builds community as well with providers. I think I know myself as a midwife I regularly participate in continuing education with other midwives, and it's really great to be with other midwives and to have an activity where you're learning and growing together, but it's not just being really stressed at work. while midwifery is a beautiful job, it's a stressful job. And, you know, the building community and team building and morale boosting with other midwives has a lot of benefit to the community as well. When they get to know each other and people can share also different things that they know. There were a lot of things that happened during with each group where people shared different skills or different, you know, tips or tricks that they learned or that are more common in the facility that they work in, and they were able to share it with other midwives who maybe were less familiar or, you know, practiced something differently. So that was also a great added benefit of the team building activity. Oh, 1 second, sorry. Something is happening with the slides that are not in order. So in terms of ongoing sustainability of the project, something that we would really like to continue to work with Busoga Health Forum and the Jinja region is to continue to have simulation training. The 2 simulators that we brought stayed there, and so that they're there now for usage, and we really hope that they will become a regular part of the healthcare community there to have simulation training. Different ways that we can help support the sustainability of ongoing trainings is with free resources. During our training, we showed some videos both from Ariel Global and a few different organizations that have really excellent online training platforms that have free materials that are available. We also had handouts and training materials and booklets. Sharing with coworkers. So we asked that everyone who attended the training, if they learned something from it that they felt was really valuable, that they go back to their facility and share that with the other midwives that they work with, or the other providers that they work with. So that if not everybody can access training all of the time, but if we are able to train small groups, that they kind of perpetuate that learning by sharing it in their facilities. It's really important for the sustainability of a training program to eliminate barriers for participation. So part of that is providing travel stipends or meals to make it free and easy to attend a training, which is part of what we did. And we also recommend that we can work with Busoga Health Forum or any organization that wants to partner to continue the simulation training, to have somebody who is a training coordinator. And the training coordinator would be responsible for scheduling and executing regular training opportunities for the community. Ideally, I believe that person should be a midwife, because I think that somebody who does that work every day and really understands the challenges is the best person then to keep teaching others and to work on that development in the community. And working with, you know, sponsorship through private grants or NGOs or other organizations. There's a lot of, as I mentioned before, there's a lot of large organizations in the global healthcare space right now that are really promoting simulation education. So I think there's a lot of opportunity to tap into those resources to grow a program in this region. And the ideal would be that every midwife in the region is able to attend a training at least once a year. And that's for both continuing education, to practice and improve their skills, to get all of the benefits that we discussed. Some potential funding partners for creating or growing the simulation training program: USAID, philanthropic donations, Gates Foundation, WHO, Ariel, Partners in Health. There's a lot of investment in this area right now, and I think that it would be really wise to try to tap into that for Jinja. I tried to include lots of pictures of the training because I think it was a really great experience. There was a lot of joy in it too, to really see everybody kind of getting into that role of of being an actor. So people would take turns being the mother, being the midwife. Obviously everybody is a midwife, but taking turns being in that role and also giving each other, you know, feedback, which is really important. Part of simulation education is feedback. And we want feedback to be positive and constructive. And I think everybody did such a great job about that. So this is just a little bit more about what we learned from the midwives. As a midwife myself, I've told a lot of people this now after I got back, but I felt like this was one of the proudest moments I had to be a midwife and to get to call myself a midwife in that community. In the US, midwives are often looked down on a lot by the health system, that we're not equal providers or we're something different. And I think that's a shame because globally, midwives are the leaders in maternity care. And midwives are really at the front lines of providing excellent care around the world. And midwifery is a really special profession. Obviously, I think we need doctors, we need excellent obstetricians, we need all of those resources available. But midwives are really the keepers of normal birth processes and pregnancy. And I think that's a special skill, and that's a special sisterhood to be a part of as well. So I was very proud to call myself a midwife, to be there and to really see how important midwifery is in the healthcare system in Uganda. I learned how resourceful the midwives in Jinja are. They should all be so incredibly proud of themselves, because like I said, you know, to think every day about what you have available and how you're going to use that, not knowing what's going to walk through the door. You know, are you going to have 5 babies today? Are you going to have 20 babies today? Are you going to have, every birth is going to be normal? Are you going to have complications, right? You never know. And I think that they're so incredibly skilled and dedicated to their work to show up every day for the women of their community and provide really excellent, dedicated care. Everybody that we met was so passionate about midwifery care and improving maternal health care. People said over and over again, like they wanted to be a midwife because they wanted to improve maternity care and they want to see better for their community. And I think that's a really honorable thing. People were so engaged during the whole process and asking questions, being really enthusiastic about the training. So that was really exciting. And they're just so eager to learn. So I think finding ways through simulation training, through other opportunities, online training, to continue to offer continuing education is really important, because we really saw people were very passionate about wanting to improve their skills, learn more. I think everybody in healthcare, like we always want to be doing better, right? We want to be better providers all the time. And we do that through experience, but we also do that through education. So we were really honored to be able to work with Busoga Health Forum and get to know especially Dr. Agri, who was with us through the trainings and was so helpful, and Moses and Dorothy and Benjamin. I didn't personally get to meet Professor Peter, but I know he was a big part in helping this happen. And we were really excited about this partnership and wanting to help continue this program as well and support it however we can. This is just a picture. I loved this picture because I think everybody was really shocked that I got up on the table to pretend to be the mother giving birth. But part of simulation training is you want to make it as real as possible, right? So if you just have a dummy on the table, it's not making noise, it's not moving, but we all know, you know, in birth that there's a lot of things going on and you have to talk to the person and have them, you know, they're obviously an active participant in what's going on. So it was really great. We really got into it and really got to try to, you know, have the full experience. Sometimes we would run the simulation that the participants wouldn't know what the emergency was ahead of time, so that they would have to just ask the questions and respond to it, because that's what happens in real life, right? We don't know what the emergency might be until it's happening. And we're really hoping that this continues and that we can support this to continue, and having multiple trainings take place a year. I forget who made the joke, but somebody said they're going to add onto the name of the building, where it says Education Center, Education and Simulation Training Center. So that would be, I think, the dream, that there would be a dedicated facility. Yeah, and I'm happy to answer any questions, and I'll leave this up too with my information. And I'm happy, like, people want to reach out and keep discussing these things. I'm really passionate about this, and I really want to see this program continue and support it however we can. And I think just in order to leave time for questions, maybe is now a good time to stop.
Okay. Thank you very much, Ariel.
Vivian, you're mute.
Thank you very much, Ariel, for the great presentation. To everyone that has logged in, I can see we have 91 attendees, and we are really so grateful. So thank you very much, Ariel, once again, for the great presentation about simulation skills training for obstetric emergencies. Very great presentation. And it's just 11 minutes to 9 p.m. So I'm going to request those that have any questions, feel free to go into the chat area and you put your question there, but also feel free to raise your hand so that I can be able to note you and then give you an opportunity to say something or even to ask a question. And I'll start with Hadija. Over to you, Hadija. I hope you can be able to unmute. Thank you.
Yeah, thank you so much, moderator and Ariel. Kindly confirm that you're able to hear me, Lillian.
Yes. We can hear you loud and clear. Kindly proceed.
Okay, my name is Hadija Nakatude. I'm a midwife. I work with the Reproductive and Child Health Department, Ministry of Health, and I am a very good support a supporter for midwives, especially the ones who are working in Busoga region. So I have like 3 questions to Ariel. One is about sustainability of the project. That the midwives, the ones that were trained, were they master trainers or they were midwives who were ideally participants? Because what we are looking at is, if we want to have continuity of midwives beyond Jinja Regional Referral, we have to make sure that we have trainers who will be able to scale down these trainings to the lower facility, for the fact that Jinja Regional Referral is the biggest CMO facility that we have. So were they trainers or they were master trainers? Because we want to have also a scenario where you don't have to all the time come back to Uganda, but we have midwives who are trained and they can go down and do the trainings. Then one of the other reasons that we are grumbling with in Busoga region is the attitude. It may not be only Busoga, we know this cuts across, but for the fact that I support lots of work of midwives in this region, we have lots of attitude problems. So Ariel, how are we able to incorporate in a component of customer care or attitude in such simulation trainings? And probably the last one is my ask to Busoga region, is we've noticed that so many trainings or so many sessions are being led by doctors, obstetricians, and gynecologists and surgeons. How best can we support the nurses and the midwives to come on board so that we have more sessions led by the nurses and the midwives? Thank you so much.
Thank you.
Okay, thank you very much, Hadija, for those. Ariel. Is it possible to note them down so that we have like maybe 2 more people, then you respond for the first time and then we get another batch like that? Is it okay with you?
Sure.
Okay, thank you. So let me see another person with their hand up. Please go into the chat area and put a question, or you can raise your hand. Let me see, just to be very sure that we don't have questions, just to be very sure. Okay, so I'm going to request Ariel to respond to Hadija as the colleagues go ahead and put their questions in the chat area so that she can be able to respond to them. Over to you, Ariel. I'll be coming in for Lillian Kadu and Professor Peter Waiswa. Over to you, Ariel.
Yeah, I think what Hadija just said is very important, that we need to have people in the region that can do the trainings. I think for the first time, it was, you know, that we came in and tried to guide that. But I would ideally love to support that somebody locally becomes the trainer and learns how to do that through working together with myself and Cathy or other mentors to help them feel confident that they can teach the training, and then they're the person in the region that does it. Because I think the most important part about sustainability for any community is it has to come from within. If it's always an outside group, then we're not helping the community be, you know, have ownership over their own program and the confidence to have it keep going. So I would love to, you know, work with Busoga Health Forum or Ginger Regional Hospital, any organization, to identify a person or multiple people that would like to become the simulation trainers and then, or maybe who also have experience as midwifery educators, and keep it going. That's my goal.
Okay, thank you very much, Ariel. How about, could you be having a response about the attitude, for the midwives generally all across the country?
Yes. I think that having community building activities, opportunities for midwives to come together and support each other could be helpful for that. In the US, we talk a lot about provider burnout as the term. You know, when you're under a constant amount of really high stress and you deal with a job that has, you know, really intense emotions involved in it, especially if you know, have difficult outcomes, maternal loss or infant loss, and having enough support to go through those experiences and then continue to work, because it's difficult to maintain empathy when you're dealing with very difficult things consistently.
Okay, thank you very much. I know that the other consultants, we shall be responding to them. Thank you, Ariel. Over to you, Professor Peter Waiswa.
Thank you so much. If they can mute some people who are speaking. Ariel, it's nice hearing from you. My apologies that I missed meeting you. At least I was lucky to meet Cathy in Boston.
Yes.
But anyways, we are grateful that you came. I was traveling. I wanted to actually talk about a few things. I agree with almost whatever you said, but one is the approach training, especially where midwives are invited in a central place, and yet they are going to practice from somewhere else. As you said, midwifery care is a team effort. I know you said they could go and train others, but would you think that in the future, the training is best conducted on site where the midwives practice, so that it is an entire team that is trained? The second one is like, in fact, I think in Mbala University Hospital in Western Uganda, they are going to have a stimulation center. So we hope some of these partners that work with us in the region can support Ginger Regional Referral Hospital. to have a simulation center. The last one is we actually, about 5 years ago, we had the project we were running, Gates funded with UCSF, which was focusing on care for preterms, but actually it was care at birth in a way. And we did a lot of simulation trainings. We even gave a lot of these dummies to facilities. And for me, the main issue of, I think you brought it out well on sustainability. And it is not actually for you to necessarily to answer that, but to raise it to the people in on this call that we need to establish mechanisms to ensure sustainability. And if Agro is online, but also Adija is here, I know there is a lot of mentorship, there is a lot of support supervision, there is a lot of MPDSR going on. I don't know how this can be linked to this training as a way to sustain the skills, but also for continuous training. So most of what I've said are comments, and we at Busoga Forum will be happy to continue working with you. And Adija, I expect you to, and the Agri to respond on how to take this forward, because Ariel came with Cathy to support us, but definitely we need to take it forward. Thank you.
Yes, thank you so much. I think that the ideal scalability for a training program would be that there would be a simulator model at each facility, so that the midwives and doctors at each facility can set aside time to practice semi-regularly and have that really ingrained in the culture of that facility. That is often a goal here in the US, that every hospital has ongoing training opportunities for all of their providers. And I think that that would be the ideal situation as the program grows. I think for now, having it in one location, because there's the two simulators are there, that either the two simulators would be moved around so that training can be offered in different locations, or they stay in one place and people come there. But certainly the idea would be, as a training program grows, to offer, to include as many people from different facilities as possible, and to have people be able to train locally. I saw also one of the questions in the chat, I think, was a similar thing, but the midwives that came to the training that we offered, they were not just from Jinja Regional Referral Hospital, they were from many different facilities, and they traveled there for the group training. So ideally, you know, as funding would become available, then the goal would be to purchase something like a Mama Natalie that also has the neonatally, and have one at every facility, so that people can have them for practicing and training and also reviewing. If you have a very complicated, difficult birth and people want to really go over what happened and what can be done differently next time, sometimes simulation is a really great way to kind of role play through what happened as a team and talk about it and think about what could be changed. I hope that answers your question.
Okay, thank you very much, Ariel, for the response and to the different questions, and also for commenting on what colleagues have asked. Just going into the chat room, and I think you have responded to some of the concerns. We have Helen Naigaga, who says that how best shall this program support in improving the skills of other midwives in other lower facilities in the region, as you realize Busoga Health Forum is not implementing in the whole of Busoga. I think you have tried to respond to that, but in case of anything, you will add on. And then someone is saying that, is this program of the training in only Busoga region? That is Mugoya Rachel, and she was wondering how about other regions. Then we have Naigaga goes on to say, do we have plans for exchange visits to Jinja Regional Referral Hospital for the lower health facilities to better appreciate the simulations conducted, which you have tried to respond to. By case of anything, kindly add on so that we can be able to conclude, because it exactly 2 minutes past 9 p.m. Over to you, Ariel, to give any other additions. Thank you.
So just quickly, for this program, this was really a pilot program for us that Cathy and I worked with, input from the members of Busoga Health Forum to create, but it certainly was not designed that this was the limitation of it, but really this is the beginning of it. And I would love to see it continue so that throughout the region, people are involved. And I think as simulation training becomes more ingrained in midwifery practice and midwifery education, that the uptake of that will grow in different communities. But for now, our goal was to help support it through Busoga Health Forum in Jinja and the many different medical facilities in Jinja where maternity care is offered.
Okay, thank you very much, Ariel. And since you're looking for one of the funders or sponsors, and I do work with Aga Khan University, part of our program that I lead as the Continuous Professional Development Coordinator, we do conduct trainings for midwives and nurses across Uganda, and the Basic Emergency and Obstetric Newborn Care is one of our programs, which actually automatically we involve the different, simulations for the different obstetric emergencies, not far different from some of them that you are actually, or that you are training midwives, so on. So maybe we shall keep in touch so that we see how we can be able to work together and also ensure that we can provide these services to not only Busoga, but also to our colleagues from other regions since they are concerned. So I can see Hadija's hand is up, but Lilian Kadu, do you still have your question, or we can once again give Hadija an opportunity to say something?
Lillian, I just wanted
to
Cathy is here too, so I just wanted to say hello to Cathy because she was equally a huge part of this project. So
hello everyone.
Thank you very much, Dr. Cathy, and we are glad to have you online.
Thank you.
Hello.
Lillian.
Okay, thank you very much. Over to you, Hadija, once again to say something.
Yeah, thank you so much. I just wanted to respond. Prof had asked me to respond to how I think we are going to scale up some of these simulations to the facilities. Now, Ministry of Health works so closely with the local maternity and neonatal systems, and of course works closely with Busoga Health Forum. So Dr. Pameka is not on the call, but for as far as I know, we are moving away from taking participants to hotels and then maybe going away from classrooms teachings. We are taking the trainings closer to the health workers, that is in their facilities, because we have seen it work. Prof, I think if we could have Ariel and probably Dr. Cathy support us with more simulators, then I think it will be an opportunity to work on having experience as we take the mentorships and the trainings to the facilities where, and this actually, I want to pose a question to Ariel. I heard her saying, were they only given to Jinja Regional Referral where they trained from, all other facilities, so that when we go back to the communities, we are able to track good use of the simulators and equally use them alongside with the on-site mentorships. I hope, Prof, that answers your question, really.
Okay, let me answer. Let me just give a quick answer before I go off. The simulator that were left behind are even currently now in Kamuli. So the Busoga local maternity is really putting it in good use. It is rotating around the whole region for the trainings, but it's really not enough, and we are looking for ways to get more, because we also have more models from from another project, which are 3 projects, and they're all being used in the whole region to make sure that we improve the trainings together with the local maternity and other systems. Thank you.
Oh, that's great. Thank you. Over to you, Ariel.
Yeah, that's wonderful to hear. I think that's absolutely should be the goal, that to have more simulators and to distribute them throughout the region so that everybody has the opportunity to keep using them. I think having regular group trainings is also useful and different than having the simulator in your own facility to practice with. And I think both things have a lot of value, and a lot of growth can come from both situations. So it's really excellent to hear that they're being used, and they're being used throughout the community. And I think I heard what Hadija said. I think both things would be the ideal, both that there's enough simulators so that there's regular practice going on, but that also, maybe once a year or so, that there's a group training opportunity that's really focused on continuing education and also really talking about any advancement in current best practices.
Okay, thank you very much, Ariel. Once again, our lovely participants, attendees, we are so grateful. Thank you very much for logging in today in high numbers. We almost hit 190 participants, or even 200. So really, Ariel, I think people got attracted to the topic that you had to share with us, and you have done justice to it. So we do really appreciate you with Dr. Cathy, and we can't take your efforts and time spared for granted. To each and every one of you that has been able to log in and listen in and even go ahead and contribute, we do really appreciate you. So as the colleagues have said, the simulation models that are in the different centers, let's utilize them, let's use them, let's not just keep them. And as we are aware, it is continuous professional development. Things keep changing every other day, and with practice, you become perfect. So let us be our fellow nurses and midwives, dear doctors, clinical officers, and other health professionals. Let us always be open to learning every other day. They say that when you stop learning, actually, then you know that you're dead. But when you keep learning, you actually become even wiser. So let us be open-minded. Let us keep learning and becoming better every other day, for the best of Busoga region, for the best of Uganda, and also for the best of our the world at large. So once again, we appreciate you all for listening in. As we wind up, I'm going to give Desmond Tatuma to be able to give closing remarks. I remain Lilian Nwabini. Thank you very much, and over to you.
Oh, thank you so much, Lilian, for moderating this wonderful presentation. Thank you, Ariel. Thank you, Dr. Cathy, for preparing and for giving the trainings to our midwives. I want to invite Professor Peter to make this presentation, and I'm happy today with by the nurse, for those who didn't know, and I'm a proud one. Dr. Peter, kindly come and close this session.
No, just thank you, Lilian, for being a very active midwife, one person I always very proud of, for your energy, but also pushing the midwife agenda. And Ariel, thank you for your commitment, for being able to travel to Jinja. And I know you said you loved it. And for doing the training with Cathy. So on behalf of Soga Health Forum, we give you this small certificate of appreciation. I'm sure one for Cathy would also be coming because I'm sure you did this together. So thank you so much. Next, Lilian, of course, I've already said, thank you so much for always fighting for midwives, but also for mothers and babies. And just to say that I actually know Leido himself very well. So maybe Ariel and Cathy and Lilian and others, we should get together to discuss, and Hadija and others, a program for scale but also sustainability. Thank you so much, members, for joining. Have a lovely evening. Enjoy your weekend. Thank you, and God bless. Bye-bye.